Hello, I'm Dr. Julio Delgado, Chief Medical Director of the Immunology Division at ARUP Laboratories and Associate Professor in the Department of Pathology at University of Utah School of Medicine. Today, I'd like to discuss the use of test-guided management of treatment failure to TNF-alpha antagonists. Infliximab, which is also known as Remicade, is a monoclonal antibody that blocks the activity of TNF-alpha. The use of TNF-alpha antagonists, such as infliximab, has revolutionized therapy in individuals with immune diseases, including rheumatoid arthritis and inflammatory bowel disease. Infliximab is given to individuals who fail conventional medical therapy and is used for the induction and maintenance of clinical remission. However, not everyone responds to infliximab therapy. About a third of individuals experience primary non-response, which is a failure to respond during induction therapy. Its most common cause is rapid clearance of infliximab in the absence of any immune reaction to the drug. Among the initial responders to infliximab, response vanishes over time in approximately half of them. The most common cause of this secondary non-response is the production of antibodies to infliximab, which neutralize the effect of the drug. There is currently no established standard of practice for managing individuals who become non-responsive to infliximab. Commonly, a sequence of empirical steps is used for this evaluation. This begins with increasing the dose of infliximab or shortening dose intervals to address possible low drug concentrations. If this has no effect, it is followed by switching to another type of TNF-alpha antagonist to address possible emergence of antibodies against the drug. When that fails, then finally, therapy is changed to a different biological class of drug, for example, interleukin-6 antagonists, as the treatment history suggests the involvement of non-TNF-mediated inflammatory pathways. In this empiric strategy, no early attempt is made to identify the mechanisms for loss or response to infliximab or to investigate if the symptoms are due to causes other than inflammation. An alternative to this empiric strategy is to use laboratory testing to measure infliximab and antibody levels to select a new treatment based on the most likely mechanism responsible for loss of response. Support in favor of this test-guided strategy comes from a recent randomized control study in patients with Crohn's disease who lost response to infliximab. In this study, the effectiveness of empiric escalation of infliximab doses was compared to personalized therapy based on infliximab and antibody levels. The result was that the test-guided strategy significantly reduced average treatment cost per patient compared to the empirical approach without differences on clinical efficacy. Recent studies also support the cost benefits of test-guided management in an individual with treatment failure to infliximab and other TNF-alpha antagonists. Testing for drug levels and antibodies to TNF-alpha antagonists is one of the fastest growing areas in clinical laboratory. Several methodologies are available for measuring drug levels and antibodies, including ELISA methods, the homogeneous mobility shift assay, and the reported gene assay. An important shortcoming of ELISA methods and the homogeneous mobility shift assay is that they do not distinguish between functionally active and inactive anti-drug antibodies. This is critical for a more precise understanding of why therapies fail in some individuals and not in others. For example, binding but not neutralizing antibodies may be detected by these methods, but those antibodies may be transient or have no impact on treatment response because they do not interfere with the action of the drug in vivo. ARUP has recently validated a reported gene assay to measure infliximab activity and titers of antibodies to infliximab. At this time, this is the only clinical assay available for detecting antibodies with drug-neutralizing function. ARUP's infliximab assay uses reported cells that carry a TNF-inducible firefly luciferase reported gene construct. When TNF-alpha is added to the cells, the reported gene turns on and generates firefly luciferase expression. This luciferase expression is normalized relative to the expression of the Renilla luciferase gene, which is also carried within the same reported cell. To measure the activity level of infliximab, serum is mixed with TNF-alpha and added to the cells. If infliximab is present in the serum, it will block the activity of TNF-alpha, and the amount of infliximab present will inversely correlate to the amount of luminescence produced by the cells. The amount of infliximab can then be calculated using a calibration curve. To measure the titer of neutralizing antibodies to infliximab, serum is mixed with a known concentration of TNF-alpha and infliximab. If the serum does not have neutralizing antibodies, the infliximab added to the assay will block the activity of TNF-alpha and will turn off the luminescence in the cells. In the presence of neutralizing antibodies, these antibodies will block the activity of infliximab added to the assay, and the luminescence of the cells will be turned on. The antibody titer is then obtained by identifying the dilution point of the serum, where blocking of infliximab activity is no longer observed. Few studies have been published comparing different methodologies for the infliximab testing. In one side-by-side comparison made by AREDUP, serum specimens from 36 individuals were tested by the reported gene assay and the homogeneous mobility shift assay. The ages of individuals range from 8 to 71 years old. 23 specimens were from children. A strong correlation of infliximab levels was observed between the two assays with a correlation coefficient equal 0.93. 3 recent studies also confirmed strong correlations of infliximab levels between these two assays and with ELISA methods. In relation to antibody testing, the high mobility shift assay is more sensitive for detection of antibodies to infliximab. This is due to the ability of this assay to detect binding antibodies that can be either neutralizing or non-neutralizing of infliximab in vivo. AREDUP's assay, on the other hand, is more specific for the detection of antibodies that truly neutralize the activity of infliximab in vivo. Despite these analytical performance differences, the use of current assays result in similar classification and intervention in individuals with treatment failure to infliximab. It is clear based on multiple studies that the use of test-guided strategy in the setting of infliximab treatment failure significantly reduces therapy costs per patient as compared to empirical infliximab dose escalation. At this time, however, no clinical evidence exists to support the use of this testing for routine therapeutic drug monitoring. Therefore, currently, AREDUP recommends the use of infliximab and antibody testing only in individuals who develop treatment failure to drug therapy. 4 scenarios can be encountered in individuals with treatment failure to infliximab based on test results. AREDUP recommends the following decision algorithm. First, for individuals with undetectable drug and detectable neutralizing antibodies, it is recommended that the individual be shifted to another TNF-alpha antagonist. Second, for individuals with both undetectable drug and neutralizing antibodies, it is recommended to increase the dose of infliximab or shortening the dose intervals followed by reevaluation of clinical response. Third, for individuals with detectable drugs and undetectable neutralizing antibodies, it is recommended, like in the previous group, to increase the dose of infliximab or shortening the dose interval. In this group, it is also recommended to reassess the clinical condition and to rule out other non-inflammatory causes for treatment failure. This group of individuals can also benefit from using another therapy targeting a different inflammatory mediator, for example, interleukin-6. Finally, for the rare group of individuals with both detectable drug and neutralizing antibodies, it is recommended to repeat testing to rule out false positive results or the occurrence of transient antibodies. If the repeated test result is the same as the first test result, such individuals should be managed the same way as those in Group 3. In conclusion, currently testing for levels of TNF-alpha antagonists and anti-drug antibodies should be used only for the management of individuals developing treatment failure. Prospective randomized studies are necessary to establish appropriate testing intervals and clinical cutoff levels for therapeutic drug monitoring. Laboratory testing for the adalimumab, also known as Humira, is also available at AREDUP using the same testing methodology as the infliximab. Additional TNF-alpha antagonist tests are under development at AREDUP. Thank you for your attention to this video. Additional information about TNF-alpha antagonist testing can be found in www.areduplab.com/immunology.